Good afternoon. Our today's discussion will be on penetrating abdominal and thoracic injury management and our local war zone experience. And my name is Dereje Gashaw from Bahar Dar University, and outline of the presentation is we will have introduction about trauma in general, then followed by management of chest injury, and during the discussion on management of chest injuries, we will have a general highlight regarding to management of chest injury, then followed by some specific visceral injury management, specifically on management of diaphragm and esophageal injuries. And the next discussion point will be on abdominal injury management. We will have general approach to abdominal injury management, specifically penetrating abdominal injuries, and followed by specific injuries to the abdominal hollow viscous and solid organ structures in the abdomen, and this will incorporate injury to the colon, rectum, small bowel, and liver injuries. And after that, we will have discussion on local experiences that has happened during the war, the armed conflict period, and we will have real clinical scenarios that are patients who were in the armed conflict and has sustained trauma, specifically penetrating abdominal and thoracic injuries, and we will discuss on that. Finally, we'll have a gallery of the scenarios in the local area as a summary. So as introduction, trauma, as you know, is a leading cause of death in productive age group, and from this, about 25% of trauma is attributed from thoracic injuries, and the rest 30% is attributed from abdominal injuries, followed by the rest of the extremities, and the central nervous system injury will contribute the rest of the percentage. So regardless of the mechanism of the trauma, hemothorax and pneumothorax are the commonest injuries in the thoracic injury. So we'll have discussion on that. And when we say abdomen is a diagnostic black box, till the patient is explored, the severity of the abdominal structure, the severity of the trauma of the abdominal structures is not clearly settled until the patient is explored or the structures are seen intraoperatively. So diagnosis to the penetrating chest injuries, usually chest x-rays involving posterior, anterior and lateral chest radiography with metallic marking with pericardial ultrasound may be enough to manage patients with penetrating thoracic injuries. In addition to the imaging modalities, baseline hemoglobin and blood group and cross-match may be important in case the patient is going to be transfused. So majority of our patients who has sustained penetrating chest injury, they usually, about 85% of them, they usually be managed non-operatively. So adequate analgesics, either single agent or dual analgesics with proper pulmonary hygiene and endotracheal intubation and tube thoracostomy based on the patient indication may manage about 85% of our patients. The rest, 10 to 15% of patients with penetrating chest injury, they may require thoracotomy or sternotomy based on the mechanism and the trajectory of the trauma. So as we have said, chest injury, majority of them can be managed with chest tube insertion, and chest tube insertion or tube thoracostomy is the commonest procedure performed for penetrating chest injuries. So it's important to understand when and where to insert chest tube for our patients. So this diagram illustrates the traditional term, the safety of triangle. That triangle is thought to be safe because it is supposed to be free of iatrogenic injuries during the procedure of chest tube insertion. So anteriorly, the lateral border of the pectoralis major, laterally the lateral border of the latissimus dorsi muscle, and in the fourth and fifth ribs or the fourth intercostal space is thought to be the safe triangle bilaterally. So during the insertion, it's important to understand the mechanism and the indication of the chest tube insertion. When we insert chest tube for a patient who has hemothorax, the direction of the chest tube tip is different for a patient who is going to have chest tube for an indication of pneumothorax. So if the patient has hemothorax, the direction has to be posterior and inferior after we have bridged the parietal pleura. And for a patient who has pneumothorax, the direction has to be posterior and superiorly. But about 25% of our patients may have pleural symphysis, so that it's important to be careful not to injure the lung parenchyma during the insertion of the chest tube. So that very careful dissection and appropriate placement of the tip of the aortic tube is important. So there are some clearly settled indications for urgent thoracotomy, and these are as it's listed on the slide. But some indications may be modified. For instance, chest drainage, which is greater than 1.5 ml during blunt injury, or 1000 ml during penetrating injury, or if the patient has drainage of 200 ml over 1 hour for 3 consecutive hours, may be an indication for urgent thoracotomy. But if the patient comes late and the patient has drainage of more than 1500 ml and subsequently decreasing in the amount of the output, may be managed conservatively, so that it's not a clear-cut indication to have thoracotomy. The other indication is large unevacuated clotted hemothorax. If the patient is not having improvement in the symptoms, and if still the patient has radiologically settled caked hemothorax, this is an indication for thoracotomy. The other is if the patient is developing cardiac tamponade regardless of other maneuvers, and if the patient has massive air leak or incomplete lung expansion despite adequate drainage, that means the patient has the chance of having major airway injuries. So that it's one of the indications. The other indications, great vessel injury and esophageal injuries are one of the indications. So during penetrating chest injury management, one of the cause of the bleeding can be intercostal vessels. So to manage intercostal vessels, the cause of the intercostal vessels may be the primary trauma itself, or the intercostal vessels may be lacerated from fractured ribs. So that it is one of the difficult conditions to arrest the bleeding from intercostal vessels. So we have two options to settle this bleeding. One of the options is positioning our finger below the ribs so that we can access the intercostal vessels, and we can apply figure of 8 stitch both laterally and medially to access both end of the vessel. And the other is we can hold the rib with a stitch, and the immediately inferior bleeding vessel can be healed with the rib itself, both laterally and medially. So as you can see from this diagram, this is the resuscitative thoracotomy approach. We call this the clamshell extension of the left anterolateral thoracotomy. This approach is preferred for most of the mechanism of injuries. One thing, we can access cardiac injuries and major vascular injuries through this approach. But if there is a chance of having another injury on the contralateral side, we can have extension of the left anterolateral thoracotomy towards the right side, that we call it clamshell thoracotomy. But if it is difficult, if it is difficult to access all the injuries, we have another option. We call it median sternotomy. If we have major vascular injury in the central thoracic cavity, and the median sternotomy can be extended to the left neck if we have major vascular injuries in zone 1 of the chest, for the neck. And the other approach, as we have said, is the anterolateral emergency thoracotomy or resuscitative thoracotomy, because it's a good approach for most of the mechanism of injuries. So having said this, regarding to the general approach to patient who has sustained penetrating chest injury, it's a good idea to discuss on diaphragmatic and esophageal injuries in the chest. So usually patients who have sustained penetrating injury to the chest, if they sustain diaphragmatic injury, the initial wound is supposed to be very small, but it is tend to large over time. And herniation of the abdominal visceral structures is a concerning point here in the diaphragmatic injury. So regardless of the mechanism of the injury, the left side injury is the predominant one. So management of diaphragmatic injury, there is no room, currently there is no room for non-operative management for diaphragmatic injuries. So if the patient come in the first few days, especially if the patient come before 10 days, the appropriate approach is laparotomy, because one thing, it's possible to see the extent of injury to abdominal structures. Two, it's possible to reduce the herniated structures into the abdominal cavity. So it's a good idea to approach through laparotomy than thoracotomy if the patient come in acute settings. But if the patient come late, beyond 10 days, the adhesion in the leg will not be easier to reduce into the abdominal cavity. So that thoracotomy is the initial approach for patients who come late after 10 days. The other indication for thoracotomy may be posterolateral injury to the right hemidiaphragm, is because thoracotomy will not allow us to access the posterolateral injury to the left side in the presence of the liver. So the advised application of stitch is with horizontal mattress interrupted non-absorbable stitch application. Usually size 1 or 2 is recommended. Prosthetic material application is not a routine practice in diaphragmatic injury, but if there is significant destruction, it's a good idea to use biologic meshes than using other prosthetic or synthetic materials. So the other injury is esophageal injury. So any possibility that gives any clue of having esophageal injury has to lead us to aggressive investigation for esophageal injury, because delayed presentation in esophageal injury is a very devastating scenario. So either esophagoscopy or esophagogram is the advised modality of investigation, but still CT scan of the chest can give us the trajectory of the injury. We send the patient for esophagoscopy because it will show us the integrity of the mucosa, and esophagogram is important because it will show us if there is extravasation of contrast into the mediastinal structures. So treatment of the esophageal injury depends on different parameters. One of these is the duration of the trauma. The other is the clinical condition of the victim, and maybe the other one is the severity of the injury. So if the patient come early, before 24 hours, the preferred management option is debriding the edge of the trauma with primary repair and mediastinal drainage. But if our patient come late after 24 hours, we have different options based on the patient's clinical condition and the severity of the trauma. If the patient come after 24 hours with stable vital signs and the mechanism of the trauma is not that much devastating, we can do primary repair with interposition of vascularized autologous tissues like parietal pleura and intercostal muscles. If the patient is critically ill with advanced mediastinitis, and if the patient has devastating mechanism of injury, we can do cervical esophagostomy with distal part of the esophagus being stapled or closed primarily, and gastrostomy tube applied and feeding jejunostomy with mediastinal drainage is appropriate for critically ill patients with devastating mechanism of injury. If our patient is critically ill with friable or fragile esophagus, the other possible option is T-tube drainage to the esophagus. If the patient can tolerate a significant duration of surgery and stable during intraoperative procedures, the patient can be have esophagectomy with destructive patients with destructive injuries. They can have esophagectomy, and we can have gastric pull-up. With this, we are through with chest injuries. So the next will be management of penetrating abdominal traumas. So in general, penetrating abdominal traumas, the approach depends on the hemodynamic state of the patient. So if the patient is hemodynamically unstable with penetrating abdominal trauma, the right management will be operative approach. But if the patient is hemodynamically stable with gunshot wounds, and if the patient sustains anterior abdominal trauma, still the management option is right away operative approach. If the patient has right upper quadrant injury with no feature of peritonitis, the patient can be tried with diagnostic approaches. So CT scan can be sent and the patient can be followed. If the patient has CT scan that shows mechanism of injury that mandates operation, the patient can be explored. If the patient has tangential or back and flank pain, tangential or back and flank mechanism of injuries, the patient can have CT scan and still can be followed. So operative management of small bowel injury, as we all know, the small bowel is the commonest hollow viscous that sustains trauma during penetrating abdominal mechanisms. So the principle of management of small bowel injuries, examination starts with evisceration of the whole bowel towards the right side, and starting from the ligament of teres, where the evaluation has to be loop by loop, inspecting both mesenteric and antimesenteric sides for possible perforations, lacerations, hematoma, discoloration of the bowel and the like, and the mesentery has to be evaluated thoroughly for possible defects and active bleeding or hematoma. So no definitive management has to be started until the entire bowel of the small bowel is inspected for possible injury. So this is the grade for small bowel injuries. So the management of small bowel injury is grade based, and clinical condition of the patient will guide the management of the injury. So grade 1 injuries, perforations on the antimesenteric side, less than 50% of the bowel circumference, and few group of patients with grade 3 injuries, and adjacent through perforations can be primarily repaired, and the repair can be either single layer or double layer with transverse direction so as not to compromise the bowel lumen. So destructive injuries, grade 3 to 5, the preferred approach is the resection of the injury and resection and anastomosis. Duodenal injury is a bit different from other small bowel injuries because it is physiologically high pressure area, and anatomically it has connections into different structures. It has drainage from the pancreas and drainage from the common bile duct and drainage from the stomach. So this is high pressure area physiologically, and anatomically it is an confined area. So the management is a bit different. So for grade 1 and 2 injuries to the duodenum, if it is simple hematoma, the patient can be managed non-operatively and followed serially with gastric decompression and resuscitation of the patient. If the patient improves with this management, it's usually possible in majority of the patients, but if the patient can't improve in the first 3 weeks, exploratory approach is mandatory. Lacerations of grade 1 and 2 injuries, they are supposed to be repaired. In grade 3 injuries, the usual and preferred management option is resection and anastomosis. For destructive grade 4 and 5 injuries, usually this group of patients, they mandate us for damage control surgeries, and the preferred management is Whipple's procedure. So management of colonic and intraperitoneal rectal injuries, the current practice has 3 options of management. That is primary repair, proximal diversion and anastomosis, and colostomy. So there are different opinions, but the current recommendation is the patient physiologic condition is the most important point to decide whether to do primary resection and anastomosis or repair, or if the patient can have colostomy. So the patient condition is more important than other anatomic conditions. So this is a traditional algorithm for management of colon injury based on the grade of the trauma. So grade 1 and 2 injuries, the patient can have closure of the injury. For injuries with grade 3, we should see if the patient has risk factors that mandate him to have colostomy than primary resection and anastomosis. So if they have no risk, we can close the injury primarily. If the patient has risk, the patient can have colostomy with, or they can have repair with proximal diversion. If the patient has grade 5 injuries, they can have colectomy, and colostomy is the advised management option. Rectal injuries, the management depends on the position of the injury. If it is intraperitoneal, the management is similar to colonic injuries, but if it is extraperitoneal and grade 1 injuries, no operative intervention is usually required. And high mechanism of injuries, they may need diverting colostomy with distal rectal washout. But if the patient has destructive mechanisms and still have massive rectal bleeding, APR may be another option for extraperitoneal destructive mechanisms. So this is a picture to illustrate pyloric exclusion and proximal gastric gastroesophageal junction injuries. Pyloric exclusion usually is important for patient who has a significant mechanism of injury to the proximal duodenum. So it will give us time to the duodenum resection and anastomosis to heal properly. So that's the gastrostomy will be done on the greater curvature of the stomach, and the pylorus mucosa, the pyloric mucosa will be accessed and closed with an absorbable stitch, so that this will exclude the pylorus for the upcoming 3 to 4 weeks. And the gastrostomy tube, the gastrostomy incision will be used for subsequent gastrojejunostomy anastomosis, so that pylorus will have time to heal after injury to the duodenum. This is management for the proximal stomach and gastroesophageal junctions. So proximal stomach and gastroesophageal junctions, gastroesophageal junction injury, usually they will be difficult to access the injury, so that we will need to have a mobilization of the liver by cutting down the triangular ligament of the liver and mobilizing the gastroesophageal junction, then repairing the injury so as not to affect the lumen. We can consider the orientation of the injury. Then Nissen fundoplication is a good idea to have a secured repair. These are maneuvers for liver injury. So if the patient has concerning bleeding from the liver, we can follow one of this or combination of these maneuvers to arrest bleeding from the liver. This is a Pringle maneuver, the portal triad involving the common bile duct, the portal vein, and the hepatic artery will be healed with non-crushing artery, so that the bleeding from these vital structures will be controlled, and we need to make sure that the arrest shouldn't be for a long period of time, so as not to cause necrosis to the liver. The other is perihepatic pack. So this perihepatic pack can be applied both anteriorly and posteriorly, so that the hepatic injury will be managed after some time, after 48 to 72 hours. And the other option is the hepatic repair, what you call it, hepatography. This is a needle which is special for liver laceration repair, that is blunt at the tip, and a figure of 8 stitches applied with loose energy. And the other is hepatotomy. Hepatotomy can be done so as to access the bile ducts and bleeding vessels in the fractured liver. And the other is we can mobilize the left side of the omentum and keeping the right side of the omental vessels, so as to give a pedicled omental pack to fractured liver. So these are maneuvers to arrest bleeding from the liver. This is a mobilization technique to access bleeding from the retroperitoneal major vessels. The other thing, to access structures that are in the retroperitoneal area. For instance, this mobilization maneuver, extended Kocher maneuver with cattle brush approach, we can access the right kidney, the ureter on the right side, and vena cava and portal vein, so that it will be easier to arrest bleeding from these structures on the right side. So it's mobilization of the colon and the duodenum is important to arrest bleeding on the right side. So this is a diagram illustrating steps to do splenectomy during active bleeding, and left lateral mobilization to access bleeding from the aorta, the left side of the kidney, and the left side of the ureter. So this is highlight on penetrating abdominal injury management. This is to share our experience during our stay in a primary hospital near the war zone. So the hospital is some kilometers from the active war, and there was significant lack of working force. So we moved from Debre Tabor Hospital and Bahar Dar University Hospital so as to help the system. So group of surgeons, anesthetists and nursing staff has moved from Bahar Dar and Debre Tabor universities, and we have tried to organize the team so as to support the trauma. So for instance, if we take the surgical team, we have tried to organize the team into 3. Group A is supposed to be in the emergency, Group B is supposed to be in the OR, and Group C is supposed to be in the wards, and we call it floater group. So the rate limiting group is the team which is supposed to be in the operation room. So the first team that is in the OR is the rate limiting group, because once a surgeon operates on 2 patients on a row, he is supposed to be shifting to the floater group so that he can make round on his patients after he operates, and to see patients that are operated on previous days and patients being managed conservatively. So the circle was built like this, and the nursing team and the other staff has organized this way by themselves, and we have tried to settle very chaotic emergency environment by organizing a group like this. So the emergency was kind of overwhelmed environment, because when we say overwhelmed, the system has its own capacity and the problem is beyond the capacity of the system. So it was not able to manage the problem by the capacity of the hospital itself. So when we say strained, it's possible to manage by the hospital itself, but when we say overwhelmed, the hospital was not able to manage the scenario by its own. So we from Bahar Dar University and Debre Tabor Hospital and even people around the war zone was volunteering in the hospital by transporting patients and the like. So the system was in general overwhelmed. So we have involved the supporting staff during the incidents, because it was not able to cover the emergency condition by the working force itself. So the liaison officers and the like were there to repair soft tissue injuries, and the volunteers from the society were there to transport patients and the like. So there was no imaging modality in the hospital because it was highly distracted from the armed conflict. And the only thing we can be sure to have is the blood group of the patient. So this is the picture before we start to work in the hospital after the distraction of the hospital. So this is to show you the level of the distraction of the hospital. And this is, we had around 16 ambulances bringing victims from the war zone. And in a group of four ambulances coming once, and the volunteers, even as you can see, the soldiers were there to support the system. Here it's to have highlight on the emergency chaotic environment. This is one of the volunteers in around the hospital supporting the soldier to have being transferred into the operation room after she sustained penetrating abdominal injuries. So this is the meeting in the middle of our campaign after the staff of people came to visit the working force. So this is few of the working force during the trauma. So finally, I will have only 3 case scenarios to discuss patients who are managed in the hospital. So the first patient is 24 years old male individual who has sustained bullet injury to the right groin before 2 hours. And on physical examination, he is acutely sick looking with pulse rate of 102 and respiratory rate 24, and he has comparable air entry. Abdomen, he has eviscerated bowel on the right lower quadrant, dressed with blood-soaked pack, and he has tenderness specifically on the right lower quadrant. And we determined the blood group RH and cross-match prepared, and IV line secured immediately. Patient catheterized, antibiotics initiated, analgesics and TAT given, and we took him into the OR immediately. And the intraoperative finding was there was multiple small bowel perforations, and the bladder was perforated at the dome. So the small bowel perforation was multiple, and the distance between each perforation was kind of difficult to do resection and anastomosis. So as to avoid small short bowel syndrome, we did multiple resection and anastomosis. We had 3 anastomoses, and there was only urine in the peritoneal cavity. There was no significant fecal contamination, and bladder dome perforation was repaired on double layers, and the patient had catheter in situ, and the patient had significant abdominal wall defect. We tried to repair it, and we transferred the patient after multiple small bowel resection and anastomosis and bladder perforation repaired on double layers. And the patient was very well after the surgery, and he went back to rehab center with good clinical condition. The second patient was 32 years old male patient. He has sustained bullet injury to the left chest. He is acutely sick looking on presentation with pulse rate of 114 and respiratory 24. And on chest there was 4 by 3 centimeter open sucking wound at 8 intercostal space. So immediately after the arrival, we inserted the chest tube and IV line and antibiotics initiated, TAT analgesics immediately given, and we explored the patient in the operation room. And the intraoperative finding was there was transverse colon, omentum, and stomach. We actually went immediately into the operation room because this patient had omental tissue coming through the chest tube insertion site during the insertion of the chest tube. So we performed exploratory laparotomy, and the intraoperative finding was significant transverse colon perforation after inserted into the diaphragmatic defect, and there was perforation of the stomach with herniation into the chest cavity. So we reduced the abdominal structures, we repaired both the small bowel, I mean the stomach and the colon, and we repaired the diaphragmatic injury with non-absorbable stitch with mattress fascia. The last patient is 28 years old female soldier. She sustained bullet to the right chest, and she is acutely circulating on presentation with tachycardia of 116 and respiratory rate was 24. And there was blood oozing through the wound at the 8th intercostal space, and which is on the right side at the anterior axillary line. And immediately we inserted chest tube, antibiotics initiated, and all the supportive measures taken, and the patient explored. During exploration, there was injury to segment 6 of the liver and part of segment 5, gallbladder perforated at the fundus, and hepatic flexure of the transverse colon was perforated. So we did resection and anastomosis of the colon and cholecystectomy done, and bleeding from the liver was not significant. So we explored thoroughly cholecystectomy, and colon managed accordingly, and we left the drain at the subhepatic space. So this is all what I have about penetrating thoracic and abdominal injuries, and we will have post-CME questions. If you have comments, questions, you are welcome.